Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology, sponsored by EUROTIMES. I'm Oliver Findl. We're here at the 32nd Congress of the ESCRS in London. Refractive surgery is characterized by apparently endless technical innovation. How can we tell which innovations are clinically meaningful? What would we like to see? What we don't have yet? Today we will be discussing these questions with two very special guests. Dr. Mrochen of the Institute of Refractive and Ophthalmic Surgery in Zurich, and Dr. John Marshall, Institute of Ophthalmology in London. Michael, John, thank you for being with us today. Michael, you will discuss if there is any real innovation in excimer laser surgery. Are we being sold features and not advantages? So which is it?
I truly believe we are sold features with a lot of advantages for patients. And if you look on the challenges that we have today in refractive surgery, I think we still have to address predictability of the refractive outcome. We have to look on visual performance after the refractive surgery, and we have to address safety topics. If you go back to refractive predictability, I would like to raise the question, if we have to do a retreatment for refractive purposes, is that already an adverse event? So do we have to increase or decrease our retreatment rates and increase our refractive predictability?
How much of those at the moment do you think? I mean, what is your estimation?
If you look at different clinical sites, some people have very low retreatment rates because they're focusing on a particular patient group, easy myopes, low astigmatisms. But if we move into higher myopes, above 4, 5, maybe 7 diopters of myopia, or in relevant corneal astigmatism, around 2 diopters, we do see higher retreatment rates. They go up to 10, sometimes 15%.
I would take a slightly different stance. I think that commercially, companies sell features, regardless of whether or not they're advantage, because they actually need to maintain their marketplace. And sometimes when they really don't have a proper innovation, they will put in a feature, change the color, and go to the marketplace again. And in relation to outcomes, I think, again, the clinical forum is not quite as honest as it should be, because some people talk about retreatments, some people talk about enhancements, and some people talk about touch-ups. Now, in reality, these are all corrections that have not been as they should be when the patient left the clinic. So it is a very difficult area, and it's one where the numbers are really very high. And I think in the future it will possibly be addressed by innovations in terms of the laser technology, although those are difficult to see. But there's going to be some quite interesting pharmaceutical developments in terms of wound healing, specifically to tissue types within the cornea. And I think that's a very exciting field.
Yeah, I mean, you make an interesting point. I would like to go a little bit back from a clinical perspective and raise the question, if you look at the outcomes reported in the literature as well as in clinical trials, we're getting to about whatever 90–95% within half a diopter. If you just look at the test-retest abilities that we have with subjective refraction, that's in the same order. So at the moment we're getting to the point that our standard of care or standard measurement technique, the subjective refraction, is not revealing differences in the outcomes. So how can we possibly improve something without having the appropriate outcome measure for our endpoints?
Well, I think that's a similar situation though in the whole intraocular lens field. People are happy because they use a crude measurement in terms of visual acuity. And I agree with you, I think we need more sophisticated measuring techniques. As far as the laser is concerned, being an elective procedure, most of it in many countries is in private practice, so there isn't much follow-up. So the publications tend to come from academic institutions, but they're a small fraction of the body as a whole. I think from my own standpoint, I'm really pleased that we have something called the visual cortex, which is very tolerant. So we do a lot of things and we actually get away with a lot of things because the brain adapts and the patient's happy bunny.
Mm-hmm.
Yeah, I mean, actually guiding the discussion nicely into my second point is visual performance, visual quality. And I think laser refractive surgery, the market lives from excellent outcomes, happy patients that create word-mouth propaganda. And with patients having an okay vision, I think that's not the target. We need to get to excellent outcomes for every patient, independent for which refractive range you're looking for.
I mean, the factor of happiness of a patient, that's obviously something you hear very often. Oh, I've only had happy patients. I think that's a little too crude. Because as you said before, patients will be happy for all kinds of reasons. If they've had a cataract before, if they've had high ametropia, which they may have not corrected completely or incompletely. So I think that is not good enough. The problem is outcome measures. So what are you thinking of? Which outcome measures could we use, especially for optical performance?
I think there's a lot of work have been done on the level of optical aberrations. I recognize there's a lot of frustration in the clinician side of you because the numbers presented on the machines usually don't scale the quality of vision that the patient is reporting. So I think their innovation can happen, maybe moving into the field of adaptive optics and understanding better the relation to vision and the actual optical quality. A lot of symptoms, I think, are related to tear film issues. So I think we need to address that topic. And in terms of measurements, I think we have to move away from looking at a defined letter chart into visual environments that the patient is experiencing and is preferred to in his daily work, and give him visual comfort in this visual scenarios.
But I think we really need two subsets, Michael, and I know you're a physicist as well. So we both really want objective measures rather than the subjective response of the patient that we've relied on for many years. So we need some basic objective measures, and then over and above that, we have to do exactly as Michael said, putting the patient in their workaday environment to see how happy they are with the result that they've got. And my comment earlier, if you've paid several £1,000s for elective surgery, you have to be very upset to confess to your friends and colleagues that it wasn't money well spent. So that's why I'm a little bit like you, skeptical of, oh, it was wonderful.
John, you will be debating what do we have, what do we want, how do we get there? What is your diagnosis and prognosis for the use of lasers in refractive surgery?
Well, I mean, first of all, I can sidestep this by saying I'm not a clinician.
Well, that's always an easy way out.
No, and so in that particular session, it's meant to be a debate between Thomas and myself. So Thomas should define clinically what he feels he wants and hasn't got. And then my role is to say, well, in terms of current physical progress, we can supply this, but currently we can't supply that. But it seems to me that there is now a move towards platforms which have multiple functions. So some companies are looking at corneal assessment platforms, so whether it's topography, whether it's elasticity. So you get the whole spectrum of measurements that you require for your surgery in the same system that you have for the laser, or rather linked by Wi-Fi or whatever. And then in the same system, rather like the Zeiss platform, you can cut the flap and do the subsequent procedure. And I think there's an interesting development there because some people are unhappy with the quality of the flaps and the size of the equipment. And I think that the Schwinn company is doing some interesting work, actually shifting the wavelength into the ultraviolet. So multiple platforms, I think, are going to be something that we are going to see increasingly in the future. And many of my clinical colleagues say that's what I want.
But so the idea would be to have all the equipment from one manufacturer so that you can essentially also close the loop, meaning diagnosis, planning, the actual treatment and then also the post-op follow-up and to see whether you've reached what you wanted, your goal. Is that also part of the plan?
Well, some people want the sort of Apple syndrome where you have a locked-in closed loop. Other people really don't want that because they don't want to be trapped with a single supplier, etc. So there are two schools of thought there. My own school of thought is really the Apple concept, because I rather like something which has been perfected as best as can be all the way through the system. So I think that that could be an interesting development in the future.
What do you think, Michael?
I share the opinion here in terms of, I see we need to think about solutions and not of individual technologies. So for me, the refractive surgery platform in future will, by definition, include diagnostics, treatment planning, the procedure itself, or the system for the procedure, and abilities to use the post-op information to actually feed that back into the treatment planning.
But I think it's important. I mean, Michael and I have both been fortunate in terms of developing systems, and we both work very closely with expert clinicians. But it sometimes surprises me. One of my group actually, with just a very lightweight lens, switched the Hattie from an inverted image to an upright image. Now, the students absolutely loved the thought of doing VR with an upright image and everything in the place. The senior surgeons absolutely hated it and said it was positively dangerous. So we have to listen to our clinical colleagues as to what they want rather than what we think they want.
I think that's a very important point is, we addressed clinical needs in terms of predictability, safety. On the other hand is, I think, usability. I think there's a lot of work to do in the area of usability of these devices. At the moment we have a set of diagnostic tools. They somehow transfer the data to the treatment platform. Surgeons spend a lot of time in actually planning the treatment. Then it's transferred to the refractive platform. So this whole process should be simplified, make it more safer, and as much as we can integrate the diagnostic tools into, let's say, one box, I think we're going to see innovations in that area.
I mean, one problem is also that if you have very complex equipment and a lot of data coming at you from an eye, which you've measured, that then at some point you're so overwhelmed that you will only use a very small part of it. And I think that's also something which is probably important, to have user interfaces which will highlight potential problems to lead you and guide you in treatment choices.
Yeah, I think that's very important. I mean, if you think of the whole history of refractive surgery, do we really have a good method for defining the apex of the cornea in relation to the line of sight and the visual axis? Now, I find it extraordinary that after 25 years, we are still arguing about where they are and which one we should use. So I think it's very important that we have this sort of analytical approach, feedback from the clinicians to say precisely what it is they want. But you're right, at the moment we have machines generating enormous amounts of data, much of which we don't use. No, it's great for us because we get lots of numbers and we produce research papers, but I'm not sure how it helps the clinical practice or the sale of laces.
I mean, talking about complex machines and a lot of data, obviously all that also costs. What about the socioeconomic issues? Can we afford to use innovative technology today? Can we afford not to? Any ideas?
Yeah, I think that's very important. We have another session today looking at microkeratomes and macrokeratomes. If you look at the differential between a mechanical microkeratome and a femtosecond laser, it's huge. And how do you justify that? It's very difficult to justify that on the basis of outcome because they're very similar in many cases. But in one particular area, in the biomechanics, you have an advantage rather than a feature because you can undercut flap edges, etc. But you're right, and in today's day and age, it becomes increasingly traumatic in a country like mine, where we have socialized medicine for the most part, for NICE to tell us, well, it's safe, it's effective, but it's not cost effective, so you can't have it. And in instrumentation, I think that's going to happen more and more often. We're going to have some incredibly sophisticated but very expensive devices, which only a very few can afford. But I still want to go there.
I think a part of the problem is that, let's say, for the average simple case, we actually have an excellent solution already. Now, if we go into challenging cases, irregular corneas, for example, where patients will actually experience a real need to give them back functional vision, to improve the quality, to make repair mechanisms. This is just a small amount of patients, and therefore there's not really an attractive market behind it. So how are we going to deal that with their, helping patients with a real unmet medical need in getting visual performance back for functional vision, and on the other hand, having these huge development costs that are required to actually achieve those goals. So I think that's a big controversy, and I see a tendency that happening in industries that there's a little bit reluctance moving into this direction, because for good reasons there's not really a market behind that. So we have that balance, or we need to find that balance between addressing patients that have real medical needs versus the commercial aspects.
So Michael, in addressing this issue of small numbers with defined medical need, are you talking about cross-linking?
To some degree.
No, I agree. I mean, you only have to look at the field of gene therapy now, where, how is that going to be commercially exploited? You can have a platform technology, but the numbers are so small and the costs are so high, it's very difficult to see what its future is.
Anything else you want to add?
In terms of innovation, I think the times have come to a point where most of the laser platforms out there, from a technical point of view, I think they achieve the accuracy and reproducibility we need. I think we need to understand much more on the diagnostic side which information is necessary to improve, and also we need to control better the post-op behavior of the eye, so the reaction of the eye. And we definitely have to address biomechanical issues. I think we need to understand the epithelium and how the epithelium affects the refractive or visual outcome. And therefore we need innovation that definitely will then drive our treatment planning in future.
I absolutely agree. I mean, to my mind, the biggest omission at the moment is biomechanics. Whether those devices are based on interferometry or Bruin scatter, we need them. We need them in the clinic, because I think in two real areas: one, to screen those patients who have atypical biomechanical properties and exclude them, and it would be extremely helpful in terms of follow-up to see patients that are getting into a trouble situation long before they reach a true ectatic situation.
And then the idea would be, for example, to offer them cross-linking.
Of course. We both agree on that.
That's an easy one. But it's interesting, laser refractive surgery has become such a long way. We're removing tissue from the cornea that by definition weakens the cornea, and we don't have a real tool to quantify the impact on the biomechanical stability. I mean, there's a lot of simulations for the last, 30 years, but getting real data is behind it. And I think that could actually drive a next step in innovation for refractive surgery. Maybe the future laser system is really in the femtosecond area, one platform, removing a lenticle. Maybe we can go to corneal molding, doing cross-linking in certain areas and reshaping the cornea. So I think understanding the biomechanics will drive innovation in refractive surgery.
Absolutely. It's the future, I think.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.